A very big hello to all my dear students. So, how are you all? Let's start cornea today. What are the things we are going to discuss in cornea? So, this is the overview of the chapter here. We will be talking about the anatomy, physiology. Then we are going to talk about the investigations related to cornea. What are the different types of keratitis? We'll talk about ectatic dystrophy, that is keratoconus, right? And we are going to study about the keratoplasties, then corneal degenerations, corneal opacities, and corneal dystrophies, right? This is a broad outline of the whole chapter, what we are going to cover, right? Okay. Starting with, what is the shape of the cornea? We will answer, cornea is aspheric. What is aspheric? The curvature decreases gradually. So, cornea is aspheric in shape. Diameter you are going to learn as 11.5 to 11.75 mm. Right? So, of course, it is going to be more at the horizontal meridian. Something like this. Okay. What is the refractive index? This we have done in our introduction chapter as well. Refractive index is 1.37. All of you, this is your repeated question. Right? Then, power of the cornea. What is the power of the cornea? We will answer power is 43 to 45 diopters. And then comes the thickness of the cornea. So, you understand we have discussed this earlier in the introduction chapter as well, that though the index is less than the lens, but the power is much more. Why? Because of the curvature of the cornea. We had learned this, more the curvature, more is the refractive power. Correct? Okay, coming to thickness. Thickness of the cornea, how you are going to learn? We will learn thickness as centerme, it is 0.5 to 0.6 millimeters. Okay? And when you talk at the limbus, this becomes just the double, that is 1 millimeter. Right? So, it is 0.5 to 0.6 mm at the center and 1 at the limbus. How do you measure the thickness? Of course, we are going to discuss it in the investigation part as well. We do it by pachymetry. Okay, another important thing when you are talking about the diameter of the cornea, you have to also know what is megalocornea and what is microcornea. So, what is megalocornea? Has been your exam question. Megalocornea is any diameter of more than adult diameter of more than 13 millimeters, right, is megalocornea. And coming to what is microcornea? Microcornea is less than 10 mm. Microcornea, it is less than 10 mm. Okay. Once we know this, we talk about the structure of the cornea. So, structure, what are the layers? Let's have a look at this slide first. First will be, of course, epithelium. What is the next? Below the epithelium, Bowman's membrane. Bowman's membrane is a part of the stroma. Then comes your thickest layer, which is 90% of the thickness of the cornea is the stroma. Then we talk about another layer after stroma. So, this is your stroma. And of course, Descemet's membrane, and finally endothelium, isn't it? Is there any other structure we are missing? Yes. So, this is because it has been found at the in a very late stage. So, we are just learning it at the last. This is the 6th layer of the cornea, and that is your Dua's layer. Where is Dua's layer? See here. It is between the stroma and Descemet's. And let us also learn that this is one of the strongest layers. Okay. So, we learn this, it is one of the strongest layers. Anyway, we are going to talk about the details of the different layers as histological details shortly. So, next let's talk about the details of each layer. So, the first we will talk about is epithelium. Of course, we are going to see the slides, but let's learn it first here. When you talk about epithelium, this is multi-layered, not a single layer. What are the basic layers in the epithelium we should know? Sabse pehle, of course, comes the basement membrane and of the epithelium, right? Above that is your columnar cells. These are called the basal cells. Okay. So, these are the basal cells. Please draw along with me. These are the basal cells or the columnar cells. Now, they have adhesion between each other, and these adhesions are what are called desmosomes, right? So, below this will be what? Think yourself. Of course, below this would be your Bowman's membrane, isn't it? Okay, we are concentrating at present at your epithelium. So, above this basal cell would be wing cells. Okay, 2-3 layers of the wing cells. And then comes your stratified squamous epithelium. So I'm making it, let's make it like this. This is your stratified squamous epithelium. What is above that stratified squamous epithelium? If you remember, these are microvilli, right? So what are these? These are microvilli. Now all of you, one by one, what is the role of microvilli? It is increasing the surface area. Number one, okay? It increases the surface area and it helps the attachment of tear to the cornea. So we have two roles of microvilli. Please note it down. So if I talk about microvilli, we will write here. It increases the surface area and also it helps to adhere with the tear film, adhering the tear film. We come to one exam question here. They have asked you about the squamous epithelium of the cornea. It is non-keratinized stratified squamous. So epithelium of the cornea, whenever they asked you this question, the option was, answer was, so make a Q here all of you. Let's make a Q and note down. It is non-keratinized, stratified, that is multi-layered, squamous epithelium. Correct? So this is one important question. Okay. Let's talk also about one basic applied thing here about the desmosomes, or we call it hemidesmosomes. They are not exactly, they are called hemidesmosomes. And there is a defect in these hemidesmosomes which is responsible for the epithelial erosion in corneal dystrophy. So keep in mind, in corneal dystrophy, the erosion that we are getting, the epithelial erosion, it is due to defect where? In hemidesmosome. Okay. So we get multiple epithelial, we will learn about the corneal dystrophy by the end of this chapter. So this is epithelial erosion. Okay? Is it correct? Recurrent, not multiple, recurrent epithelial erosions. Main problem is here. And if there is a traumatic epithelial abrasion which is happening, it is mainly the level is between the basement membrane of the epithelium and the Bowman's. So can we note this as well? So let us learn together that between the Bowman's and basal, when there is a problem here, this is happening in traumatic abrasion. Okay? In traumatic erosion. Put it in a box, you should not forget it. Right? Okay. Let's have a look at the histological layers, how we see it in the histology slide, and then we'll discuss further about the different layers. So we have just seen here, this is your stratified squamous epithelium. Hai na? Okay, what next? This is the Bowman's membrane. The Bowman's membrane, let's learn some things here itself. Talking about Bowman's membrane, of course, it is acellular. It's already mentioned here. It's a part of the stroma. And very important, it will not regenerate because stroma doesn't regenerate. That's why there is a scarring and that's why you are getting corneal opacities. Correct? So, if they ask you which are the layers which do not regenerate, your first answer of course has to be endothelium and second would be Bowman's. Okay? So, one thing that we will learn here is that it is a part of stroma and it does not regenerate. Does not regenerate. Okay? What is it composed of? The same collagen fibrils which the stroma is composed of, and that is your type 1 collagen fibers. Okay? So, type 1 collagen. These are the points about Bowman's membrane. It's acellular with type 1 collagen. It's a part of stroma and it doesn't regenerate. Okay, we move to the next layer. So, when you talk about stroma, now next is stroma, and what does stroma contain? Stroma is containing, can you see here, collagen fibers and fibroblasts, right? These are also called keratocytes. So, if we talk about stroma, what is the main component of stroma if you look here? What are the things you are going to answer? Of course, there are keratocytes. These fibroblasts are called keratocytes, number 1. Okay? Number 2, collagen fibers, kaunsa wala? I told you just now, type 1 collagen. And of course, the ground substance. And the ground substance has, this is important, asked in exam, glycosaminoglycans. And glycosaminoglycans, primarily what you have to remember, I am going to discuss in physiology of the cornea as well. That is your keratin sulfate, okay, and second will be chondroitin sulfate. keratin sulfate and chondroitin sulfate. Right? So, this is where, and of course, 90% of the thickness is stroma. How many lamellae are stromal lamellae collagen fibers? You can learn it here. It is around 200 to 300 lamellae. Okay? 200 to 300 lamellae. And it also has some elastic fibers. Few elastic fibers are also present. Right? And what about Dua's layer? That Dua's layer is also acellular, and we have learnt it is one of the strongest layers. So, please remember Dua's layer, if you want to write, Dua's layer is also acellular. Okay. And what is next? After that, this is your Descemet's membrane, isn't it? So, and the last after the Dua's layer would be the endothelial layer. So, this becomes your endothelial layer, right? Okay. Few points about Descemet's membrane and endothelial layer. Okay, talking about the Descemet's membrane. So, Descemet's membrane you can think of is just like the basement membrane of the endothelial cells. Okay, so we will learn further that Descemet's membrane has two parts. One is banded and one is non-banded. The banded part is formed in the uterus. Okay, it is formed in utero. When you come to the non-banded part, non-banded is mainly regenerating from the endothelial cells, and because it is formed from endothelial cells, we will learn here this part will regenerate. Okay, endothelial cells, so this can regenerate, right? Okay, and after this, of course, very important point for the Descemet's membrane, we'll be learning it again and again here, is no elastic fibers. And because there is no elastic fiber in the Descemet's membrane, what happens? Whenever there is any stretching, we are talking about either ophthalmos that you have learnt in congenital glaucoma, or we are talking about any stretching during keratoconus. What did you learn? We see break in the Descemet's membrane, and that is what is called either in, if it is congenital glaucoma, we call it Hab stria. Whereas in keratoconus, what do you call it? Vogue stria. Okay? So, no elastic fibers, and therefore, it will break very soon, and this is seen in form of stria. We learn it either as Hab stria. What is Hab stria? Hab stria is seen in congenital glaucoma, and second would be Vogue stria, which we are going to learn in case of keratoconus. Okay, Vogue stria in keratoconus. Right. Another interesting piece of information here, that when you are doing a gonioscopy, what have you learned? This Descemet's membrane on gonioscopy is what you call as Schwalbe's line, right? So, we learn it. This is what is called Schwalbe's line, SH, Schwalbe's line. That was about Descemet's membrane. Next we talk about is endothelium. Very, very important. Endothelium. What are the points you have to know about endothelium? Endothelium is a single layer of polygonal cells. Okay, it's a single layer of polygonal cells. Number 1 point. Number 2, it will not regenerate, and this is your exam question. Which layer does not regenerate? Our first answer is always endothelial cells. Right? Okay. Another important thing that we have to know, because it doesn't regenerate, what is the normal number of endothelial cells is very, very critical. Normal number in adults, we will learn it as 2500 to 3000 cells per millimeter. It is square, not cube. Okay, all of you? It is per millimeter square. And if you talk about children, we will learn this as 3500 to 5500 cells per millimeter square. Cells per millimeter square. Right, all of you? Okay. So, once we know this, how do you see the number of endothelial cells? Again, we will discuss in investigation. We can examine this through specular microscopy. Right? This is important, asked in your exam again. So, we make a cue here. This is important, and this is also exam question. Right? Okay. So, once we know this much, we next talk about, of course, we will take more in detail in physiology. Another important thing you should know is about the nerve supply of the cornea, isn't it? It is, of course, the sensory supply will always be through trigeminal nerve, and cornea is one of the most densely innervated tissue in your body. Okay, so can we note this down? That cornea actually is the most densely innervated tissue in body. Okay, so of course it will start from ophthalmic division. As I said, if you discuss the nerve supply, sensory supply is ophthalmic division of trigeminal. So ophthalmic division of trigeminal will give which branch? We know this, it is the nasociliary, and this nasociliary branch finally gives the long ciliary, and the long ciliary will innervate the cornea. Now this long ciliary, we can learn further, is making three plexus here. Okay, one is intraepithelial, inside the epithelium. We will learn it as intraepithelial plexus. One is subepithelial plexus, and the third is stromal. Okay, so these are the three levels in which you can see the nerve supply. Okay, once we know this, it reminds me of a very important question here. What is neurotropic keratitis? What is neuroparalytic keratitis? We will first put exam question. These are asked in the exam. When you talk about neurotropic, we are saying this will happen if this nerve supply, that is trigeminal nerve supply, is gone. Okay, so neurotropic keratitis is due to fifth nerve. It is the fifth nerve involvement which leads to neurotropic keratitis. What is the story? Any healthy nerve supply is actually responsible for supplying lot of neuropeptides and growth factors. So what happens? That helps in the health of the epithelial lining. So once this is involved, therefore less or no neuropeptides, right? If no neuropeptides, this affects health of the epithelial lining, and when it affects the health of epithelial lining, this is going to finally lead to keratitis, and this is what we are learning as neurotropic keratitis. Come to another question. The next question they can ask is, what is neuroparalytic keratitis? When you say neuroparalytic keratitis, neuroparalytic is due to seventh nerve. Okay, this is a very repeated question. You should be very clear. Neuroparalytic is facial nerve palsy or seventh nerve palsy. What happens? Seventh nerve is supplying which muscle? Orbicularis oculi. What does it do? It closes your eyes. So this is supplying the orbicularis oculi. When orbicularis oculi is affected, the lids will not close. What do you call that? Leg of ophthalmos. Okay, so this leads to leg of ophthalmos, and this leg of ophthalmos will finally lead to, if the lids are not closing, the eye is not able to close, cornea is always exposed, and that leads to what? You will say exposure keratopathy, and this is the reason of exposure keratopathy. Okay, so this was about your neuroparalytic keratitis. Now let's see a few more slides. It's all related to what we have already discussed. So if you look at this slide, what do you see here? What we see are the basal cells. Can we see the basal cells? These are the wing cells, and these are the superficial squamous epithelium, isn't it? And of course the microvilli, which has got this glycocalyx, which helps to bind the tear film. See, we are repeating it? Okay. Again the same thing. If you look here, basal cells, intermediate wing cells, superficial cells, isn't it? And what is this? This becomes your Bowman's membrane. This is again the same histology slide which you have seen. Sometimes this can be given. So you should know that uppermost this is the epithelium, this becomes your Bowman's, right? And then stroma, Descemet's membrane, and endothelium. In the histology, we generally are not able to distinguish the Dua's layer, so we don't label Dua's anywhere, okay? So this is again Descemet's, and finally endothelium, right? So now let's talk about anatomy of the limbus. What is a limbus? Sabko pata hai? Can you see this? And this limbus is junction between cornea and sclera. We all know that. Let us discuss the detail. What we will be talking about here, what is the histological limbus here, what is anatomical limbus, and what is surgical limbus. So these three are the things we have to learn, and I'm going to tell you what are the questions asked here. So if you talk about the limbus, it's around 1.2 millimeters or between 1 to 2 millimeters width. We talk about here structure of the limbus. Can you see this? The green part is the corneal side, okay? So if this is the corneal epithelium, think yourself, we are talking about the epithelium of the limbus. Okay, so if we discuss the limbal epithelium first, so we are discussing how this transition is taking place. Okay, so corneal epithelium, how it slowly, this is the limbal part and this becomes your conjunctival epithelium. So what is the difference? What is so special about the limbal epithelium? Of course, what is different from conjunctival epithelium is it lacks goblet cells. We will note this. Secondly, apart from the epithelial layer, it has non-epithelial cells. Let's learn one, like Langerhans cells. We can't go too much in detail. It's not needed at our level, but this much we should know. And this one will contain, you all know limbal capillaries, so it contains blood vessels. And it is 8 to 10 layers thick. Correct? So, easy hai, bahut zyada kuch difficult nahi. From conjunctiva, how it is different? It lacks goblet cells. From corneal epithelium, how it is different? It is more multi-layered. It has some non-epithelial cells also. It has blood vessels also. So, all these 3 points here, it is difference from corneal epithelium. Okay? And when you talk about the first important point, this is how it is different from, this is different from conjunctival epithelium. I think it's not difficult. We come to the next part. Next thing that we will learn, see is, okay, go back here. What are these? How can we forget this? Make a cue. This is what is called palisades of wound. So once you know what is the limbal epithelium, this limbal epithelium is going to dip in this corneal stroma. This is the corneal stroma. Okay, and it looks something like this. Or if you see here, this is how it will look radially like this. This is what is palisades of Vogt. What is the question asked? What does palisades of Vogt contain? So it is nothing but dipping of the limbal epithelium into the stroma of the cornea. Okay, so what does it contain? What does it contain? We will answer it has stem cells. And this is important. So, stem cells are at the limbus. We all know limbal stem cells. They are at the palisades of Vogt. When these stems, what is the role of the stem cells? It will multiply. It helps in regeneration of the epithelium. Epithelium is a layer in the cornea which regenerates. From where? From the stem cells. So, whenever the stem cells are going to multiply, actually it first leads to a daughter stem cell. And then it will lead to the transition cells which will finally at the end form the corneal epithelium. So, I am not going detail, we are going to epithelial cells. Okay, this is how it will regenerate. Okay, so that means the stem cell itself will keep renewing itself. We don't need to be bothered about that it may go out of stock. It will never. It always, whenever it divides, it is giving a daughter stem cell. Right? Okay. So, once we know these important points, another question of your exam, all of you make a cue. What is the corneal stem cell marker? So, stem cell marker here, what will you write? Stem cell marker kya hai? ABCG2. So, it is not like the usual stem cell marker. Here the marker is ABCG2 that you should remember. These are the 2 questions. So, again, this is what is you are looking at. These are what are palisades of Vogt. Okay. We come to further what you have to understand. Further, if you see that this corneal epithelium slowly becoming conjunctival epithelium is one transition. What is continuing to what? So, epithelium is connecting to the epithelium, that is one. The Bowman's membrane which is present of the cornea, it extends and becomes the substantia propria of the conjunctiva. So, conjunctiva is mainly epithelium and substantia propria. Corneal layers you have just learned with me. So, this is how the transition is taking place. The Bowman's membrane becomes substantia propria and it is the corneal stroma which is continuing as sclera. And Descemet's membrane, do you remember we just learned Schwalbe's line which is seen on gonioscopy. And corneal endothelium, this continues with epithelium of trabecular meshwork. So, if you read twice, you will understand it's very simple. If you don't want to learn this, it's okay. But for your understanding, I had to cover all this. Right? So, we are talking about this was the epithelium transition that we know. Right? This becomes your Bowman's membrane. The Bowman's membrane here is becoming what? Substantia propria of the conjunctiva. Right? If we look at this diagram, we can understand. Then this is the stroma here. And the stroma of the corneal stroma is continuing as what? It is continuing as sclera. This is your sclera. It is continuing as sclera. And then, of course, comes the next. What was the next? Descemet's membrane. This Descemet's membrane, which this arrow is showing, this is your Descemet's membrane. And this Descemet's membrane, anteriormost at the angle is what is called Schwalbe's line. And what is this arrow showing you? Here is trabecular meshwork. So, it is the endothelial layer here, which is finally actually continuing as the epithelial layer of trabecular meshwork. Okay, this is clear now? Okay, so that was the details we have to know about the histological. And anatomically, again, you have to be clear about the angle of anterior chamber. So, this much is already clear to you. This is the Descemet's membrane. This is the trabecular meshwork here, right? And this part, this is iris, correct? So, what is angle? This is nothing but a peripheral space between iris and cornea. If this is the cornea, this is the angle. How this becomes the angle has trabecular meshwork. This one is your Schelm's canal. And this part is what is called scleral spur. Right? This part is what is called scleral spur, where the sclera is dipping inside in the angle. This is your ciliary body band and this is your root of iris. Okay? So, that is what you learn with us. Now, the anteriormost structure on gonioscopy, when we will discuss in glaucoma chapter also, it will be clear. Anteriormost structure on gonioscopy is what? Schwalbe's line. This is the Descemet's membrane, that is Schwalbe's line. Then comes your trabecular meshwork, pigmented, non-pigmented part, it is the trabecular meshwork. Then scleral spur, ciliary body band, then root of iris, right? So, if you remember this diagram, you'll never forget. And we have discussed this and I've explained you so many times that whatever is limbus outside, when you dissect, you go into the angle of anterior chamber. Hai na? We talked in introduction chapter as well. Okay. Anatomical limbus. So, anatomically, from where to where we will say, okay, it is a limbus. It is, we would draw a line. Again, just know it. You may not need to learn it in detail. But wherever this Bowman's membrane, can you see that? That is ending, right? So, this from the Bowman's membrane till the Descemet's, you have drawn one line here. The second line, of course, from the scleral spur to vertically above at the perpendicular to the surface of the eye. So, this part is, these two lines between these two parts is what is called anatomical limbus. That is called anatomical limbus. Okay. And then we talk about surgical limbus. Why? It's very important. Where are you giving the incision? If you're operating a case of cataract, right? So, if you're operating a case of cataract, mainly we have learnt in the diseases of lens chapter, there is a clear corneal incision. We have talked about scleral incisions. And what should you know? Let us understand. This is the place where the Bowman's membrane ends. This corresponds to this area and this is your anterior limbal border, right? If this is the anterior limbal border, how do we grossly understand which is the anterior limbal border? The little correction here, the blood vessels would be up to this age. Wherever the blood vessels are terminating here, I can see that becomes actually my anterior limbal border. Okay, little correction, right? So, that is the anterior limbal border, that is at the end of the Bowman's membrane. Middle would be, let's see here, which is posterior limbal. Let's first understand that. If anterior limbal was corresponding here, posterior limbal is again at the level of ciliary body band and scleral spur, right? So, you draw a line like this perpendicular, this is your posterior limbal. So, if this is the posterior limbal from the scleral spur, this is anterior limbal, that is your, where the blood vessels are terminating, that is till the termination of Bowman's membrane, and the middle line is middle limb. Ideal is to always give incision here. Because if you are going to go posteriorly, you can damage the trabecular meshwork or ciliary body, as you can see the structures here. If you are going and giving an incision at the anterior limbal border, then we have to be very careful not to damage. Look at this, anterior limbal border, this is the termination, here is the Descemet's membrane. So, you may cause Descemet's membrane detachments. So, ideally, you should just remember in a surgical limbus, what is anterior limbal border, what is posterior limbal border, okay, and corresponding, and what is the midpoint. We should always try to make an incision at the middle limbal, but when you are doing a clear corneal incision, actually we are giving it at, after phaco, we are actually giving around near anterior limbal, but you have to be very careful that you are not causing any Descemet's membrane detachment, right? So that is your clear corneal incision. Okay, I think this much detail is enough. We don't want to go in too much into it. We next talk about is physiology. So when you say physiology, what are the points we have to remember? First important thing, cornea is avascular. Except the limbal area where there are capillaries, we have just discussed that, but ultimately we have to learn cornea is avascular. Second is, what is the primary metabolism? So we will learn the primary metabolism here is anaerobic. Am I correct? No. Lens it was anaerobic, cornea it is aerobic. So we will learn primary metabolism. Primary metabolism is aerobic metabolism. So next point we will learn, it is an aerobic metabolism. So from where you are getting the oxygen? Oxygen is from air. We all know this. And nutrition? Nutrition is from aqueous humor. Nutrition from aqueous humor. There's one very important exam question. We'll first discuss that. Then we come to the next point in physiology. The third point here, after it is avascular, primary metabolism is aerobic. What is the third point that you have to know? It is dehydrated. So we are saying that cornea is dehydrated. It's very important. Any corneal edema will be leading to corneal haze, and that can lead to transparency is lost, and that will cause diminution of vision. So dehydration of the cornea is very, very important. Dehydrated. So that is the third important point in physiology that you have to remember. But how come it is dehydrated? If you look here, cornea is all around surrounded only by water. It is aqueous humor. So the main important thing that you have to understand here, it is all due to endothelium cells. They are acting as a barrier. They won't allow the water to enter. But are they ever going to be a foolproof barrier? No. Some water can still enter the cornea. What is very important is, whatever water enters the cornea is immediately pumped out by sodium, potassium, ATPase pump. Okay? So this is pumped out by sodium, potassium, ATPase pump. And when it is pumped out, this pump mechanism, it is called pump function and barrier function. So it is the pump function and barrier function of endothelial cells. Okay? I think we can remember this is responsible for keeping the cornea in a dehydrated state, and that means how important it is to have some appreciable and normal number of endothelial cells. Also because it doesn't regenerate. Endothelium does not regenerate. Okay, so after knowing these three main important points about physiology, we come to the next very important discussion. Let's solve one question here. So when there is a corneal edema, the question was, is it due to activation of anaerobic glycolysis or is it due to inhibition of anaerobic glycolysis? Your answer should be activation. Let's explain how. So I think this is clear to you. When we are talking about primary metabolism, both are present. We are talking about which is primary. So primary of course here is aerobic. But when there is an activation of anaerobic glycolysis to some extent, what happens here? You all know it produces lactic acid, so lactate is formed. When the lactic acid or lactate is formed, it leads to metabolic acidosis. Okay, and when there is metabolic acidosis, this is going to cause very important inhibition of the pump, inhibition of endothelial pump, sodium, potassium, ATPase pump. Definitely, if this is inhibited, we all know cornea cannot remain dehydrated, and if cornea cannot remain dehydrated, there will be corneal edema. Okay, so this is the cause of corneal edema. Got it, all of you? Okay. We next talk about, once we know this much, let's make our basic diagram again and we'll discuss something more here. So we know this is the epithelium, this is the Bowman's membrane, this thickest part is stroma, this is Descemet's membrane, and this is endothelium. I am creating a gap here and I am drawing the endothelium like this. Okay. Now, what did we learn? Main endothelium role is maintaining the cornea in a dehydrated state. Right. Think yourself. Normal number of endothelial cells you have learnt with me. Now, what happens when the endothelium is damaged? I said it doesn't regenerate. So what happens? There will be morphological compensation. And of course, if the endothelial cell is damaged, pump function is gone, the remaining endothelial cells will take over the pump function so that it is all compensated and cornea is still dehydrated. Right? You understand? So, changing what happens, suppose this is the area where there was some damage. Correct? So, if there was a damage here, the adjacent cell is going to enlarge itself, change its shape and cover the space. Enlarging is called polymegathism and changing of shape is what is called pleomorphism. So, can we learn this together? That the morphological compensation of endothelial cells is through polymegathism and pleomorphism. And I just told you, of course, there is functional compensation as well. So, if there is a damage, the remaining cells will take the function. But there has to be a limit. That is asked in your exam. What is the limit? So, if the number of endothelial cells are less than 500 cells per millimeter square, we are talking about square, then now the compensation is not possible. Exam question, see, I have already made a cue. Please note it down. If compensation is not possible, what will happen is edema, right? So, no dehydration means edema. Initially, it's a stromal edema. Later, it becomes an epithelial edema. And lastly, what you see is bullae filled with fluid. And this is what is called, when the bullae are formed, we call it bullous keratopathy. This is what is called bullous keratopathy. So, bullae are nothing but blister-like elevations on the epithelial layer. It's a very painful condition, right? Epithelium has a dense nerve supply. So, you have to understand that no compensation is leading to edema and more edema. First, it's a stromal edema, it is epithelial edema, and finally, it is bullae formation. So, can we also, when there is no compensation, what do you call that situation? We call it corneal decompensation. So, we can say this, that bullous keratopathy is occurring due to corneal decompensation, or is a sign of corneal decompensation. Okay? So, once we know this, then we next talk about what are the factors for maintaining the transparency of cornea. Okay? When you're talking about the transparency of cornea, it's again very important, all of you. Transparency of cornea, what are the factors? Let's make a cue here. It's an exam question. We'll draw our own diagram here. So, again, we will learn layer-wise. Make it simple. Believe me, we don't need any mnemonic. It's more common sense, layer-wise. Epithelium. Just let us learn. Actually, transparency, even before epithelium, we should know that there has to be a proper tear film. Okay? If the tear film is disturbed, definitely the vision goes down. Okay? I've seen patients in my OPD wondering what is wrong, why the vision from 6 by 6 is 6 by 36. It was severe dry eye. So, severe dry eye, when it is actually affecting the layer of the tear on your cornea, will cause loss of transparency. You can say that will also cause diffusion of vision. But yes, when you talk about the transparency and the proper vision, the first thing here will be regular arrangement of epithelium. If you talk about the corneal layers, regular arrangement of epithelium, one of your options says no mitotic clumping, and regular arrangement of epithelium is number one. Take. Second, of course, is your regular arrangement of stromal lamellae. We have learned there are 200 to 300 stromal lamellae. Which type of collagen? Collagen type 1. Now, absolutely there is no scattering of light and the light is going through and through. Because this stromal lamellae, the distance between the two lamellae is said to be less than half the wavelength of light. That is one of the theories. Okay. So, how is this definitely spaced collagen fibrils possible with such a proper spacing? It is due to the glycosaminoglycans, and this was your exam question. Mainly the first option we have to answer is keratin sulfate. I think we have just done this, and second would be chondroitin sulfate. Got it? Okay, that is next factor. We come to the next layer. We are talking about endothelium. We will learn here. It is the pump function and barrier function of endothelial cells which is keeping the cornea in a dehydrated state. What else? Next point, all of you, avascularity of the cornea. Cornea is avascular. That is also another factor. So, 1, 2, 3, important. Fourth factor, this one. Fifth factor, avascular. Is there anything else we have to learn? Yes. If you are going to study acute congestive glaucoma, where the pressures go more than 60, up to 60 millimeters of mercury, we are getting again edema. So, very important is normal intraocular pressure. Why? Why is the transparency lost? Because the basic stromal pressure of the cornea, the IOP should be less than that. Whenever the intraocular pressure goes more than the corneal stromal, so we will learn here what is the normal corneal stromal pressure. Corneal stromal pressure, we are going to say, is around 53 to 55 millimeters of mercury. So, whenever it is more than that, it can lead to edema, and therefore, a normal intraocular pressure is also a very important factor. If you want to add more, the nerve fibers are not myelinated, even that helps in keeping the cornea in a transparent state. Right. So, these are the factors and these are the questions that you should remember. We next talk about investigations related to cornea. Right. So, when you say investigations, first is keratometry. Number 1, note down keratometry. What is keratometry doing? Let's make a diagram here. Of course, this is the keratometer in front of you. This is Jewell-Shiot's keratometer. Now, this keratometry will take a reading of central 3 millimeters of the area of the cornea. Okay. So, this is the optic zone. It is going to measure the vertical and horizontal of the optic zone. Right. So, the vertical one is called K1 and the horizontal is K2. So, it is measuring the curvature of the cornea. Number 2 point, central optic zone is measured. K1 and K2 are the vertical and horizontal meridian. Okay. So, you want to write, it is measuring the curvature of cornea. So, you can get an exact measurement in terms of diopters or in terms of radius of curvature. Okay. What is keratoscopy or Placido's disc? Where I am actually finding out the rough assessment whether the cornea is regular or not. So, suppose you are my patient, I have the Placido's disc. You can look at the Placido's disc. It's nothing but a cardboard with a central hole and the different circles of black and white, as you can see here in the slide. So, I am showing this in front of your eye. If the picture of this disc on your cornea is almost the same, your cornea is fine. So, it's a rough assessment of the curvature. But if you have keratoconus, then this is the picture. Steeper the axis, closer will be the circles. Okay. So, in steeper axis, it becomes closer circles. And this is a normal aspheric picture that you have to understand, you can get. So, it's just a rough assessment. Very quickly, I would want to know, okay, your corneal curvature is normal or not. This is also called keratoscopy or Placido's disc. Based on the Placido's disc is another investigation. This time it is not rough assessment, but we can actually measure the different curvatures of the cornea is corneal topography. Again, the marks are shown on the cornea and there is a color coding. The depiction is in a color coded manner, that is steeper the axis goes into warmer colors, that is it will show as red, and flatter axis will show as cooler colors like yellow. Okay. So, again this is the, how is it different from keratometry? This is scanning the whole cornea, not only the central, it will scan the whole cornea. And secondly, it is based on principle of Placido's disc. Principle of Placido's disc. If you want to write, you can write. Okay. Okay, we come to the next. In keratoconus, what you will see, if we look at the picture of a patient of keratoconus, what we see is this central area being red. This is the steeper axis, as I told you, right? Lot of details, I am not covering it here. We can cover a little bit more in the different chapter where I've included a few more investigations or videos, because you can have the idea, but because it is not asked in the exam, I'm not covering it in this flow. Okay. Okay. Otherwise, another thing is, once you know about corneal topography, what is corneal tomography? You should know this also, right? So, when you say this is topography, correct? So, corneal tomography actually is taking a 3D image of cornea. Please note it down, all of you. It takes a 3D picture of the cornea. Okay? And it is going to scan both anterior and posterior. Corneal topography was only anterior. This is scanning both, and you know keratoconus starts from the posterior surface of the cornea. So, it is even more reliable, and the main instrument that is called pentacam. The instrument is called pentacam. Okay. So, it will take both the posterior and anterior surface. Both are scanned in this pentacam. Can we note this down, please? So, you should know corneal tomography is different. Corneal topography is different. Right. So, next investigation after this is, this has been your exam question. We put a Q here, right? And this is also exam question, that is pachymetry. And pachymetry is what? I told you, to measure the thickness of the cornea. All of you note down, thickness of cornea is pachymetry. Right. We come to the next. Next is specular microscopy. We'll make a double Q here. Okay. So, this is again very important. Specular microscopy is to examine the endothelial cells. Examine endothelial cells. I talk so much about endothelial cells, about morphological compensation, about the number. Everything, all details can be seen, and generally this is how you are seeing the examining how many cells have undergone polymechanism or pleomorphism. There's another important thing. What is corneal guttae? Let's discuss a little applied here. Corneal guttae are nothing but collagenous protuberances. Okay? And when you do a specular microscopy, they can be seen as hollow spaces here, and it's a feature of corneal dystrophy, which is called Fuchs endothelial dystrophy. Okay, we are going to learn it here. Fuchs endothelial dystrophy. So, what did I say? That these are corneal guttae. Let me give you one more interesting piece of information here. So, if you look at the collagenous protuberances, if you see at the periphery, if they are present, it is generally considered normal. We call them Hazel-Henle bodies. But anything which is on the central part, now this is mainly corneal guttae, which is seen in Fuchs Fuchs endothelial dystrophy. Right? Let's write like this, corneal guttae. Okay, so that was about specular microscopy, again an exam question. What is this? How do you see the corneal sensation? If you look in the OPD, we are using a cotton wisp. Touch at the side. Of course, you don't have to touch in the visual axis, otherwise anyway we will blink. So, from the side you are touching the cotton and seeing the blink reflex. How swiftly there is a blink reflex. So, you can compare the two eyes and know whether it is affected or not, or you can compare with the normal, right? So, that is one commonest way of seeing is, that is with a cotton wisp. But what is the another instrument? This has been your exam question. The instrument is called aesthesiometer. Okay. What is this? Can you see this here? So, this length of this whole thing, this length is 60 mm or 6 centimeters. We are touching it with this at the side of the cornea, seeing the blink reflex. We keep shortening 0.5 centimeters and keep checking. If shorter length I can see the blink reflex, that means the sensation is lesser. Okay. So, this is how you can measure the corneal sensation, that is through aesthesiometer. This is also exam question, we will put a Q on. So, once we have discussed this investigations related to cornea, we next talk about is, what is an ulcer? What is an ulcer? How do you define an ulcer? Everybody knows? Ulcer is nothing but breach in the epithelium. So, if this is the epithelial layer, so any breach in epithelium, or that means any break in the continuity of the epithelium, this is what is called ulcer. Okay. So, this breach, please note it down all of you. So, it is a breach in the epithelium. What else is happening? There is some infiltration and some necrosis. With infiltration and necrosis. of the tissue. Now, if this is your cornea, majority of the infections in the cornea and keratitis, we are going to learn the different keratitis, bacterial, viral, fungal, and so on. Majority of the time it is why? Because of this ulcer formation, right? So, majority of the infection will happen because there is an ulcer, there is a breach, either because of this, or what could be the second cause? Second, it could be any immunocompromised patient. Anyway, we are talking about ulcer at present. Let's not get confused. So, whenever there is an ulcer formation, there can be infection in the cornea. But there are few organisms which don't need even an ulcer formation and they can penetrate intact epithelium. I am not saying pura and intact cornea. I am saying intact epithelium. So, there is a difference. Okay. So, what are the organisms that can, this is important exam question, which can penetrate intact epithelium? Intact epithelium, right, which can penetrate intact epithelium. What are the organisms? We are going to learn this with a simple mnemonic here, NN-LDH. LDH, you know what it is. Last entry is S. NN is both Neisseria. Okay. So, it is Neisseria gonorrhea and Neisseria meningitis. Neisseria meningitis. L stands for Listeria. D is diphtheria. Then comes your Haemophilus. And what is the last one we will learn? It is Shigella. Okay. So, what did I say? This is exam questions. NN-LDHS has to be remembered. These are the organisms which can penetrate intact epithelium. Right. So, once we know this, we come to keratitis. Keratitis is inflammation of the cornea. So, what is the keratitis? It is inflammation of cornea, and inflammation and of course later infection. When you say this, I just told you either it is happening due to some ulcer formation or it can happen in immunocompromised patients. Right? Okay. Now we talk about one by one. First is bacterial keratitis. Give the heading, bacterial keratitis. Okay, before I go to bacterial keratitis, let's understand something here. Whenever there is a keratitis, whether it is bacterial, fungal, viral, right, or acanthamoebal, the presenting features are almost overlapping. So, I teach them as 5 or 6 fingers. You can learn it. 5 fingers or maybe one additional, that is. So, just learn with me what can be the presenting features in all these types of keratitis, right. There may be some mild variation, but this is what we have to learn. To make life simple, clinical feature which fits everywhere, the presenting feature, let's make the 6 fingers. So, one is your pain, always there, redness, right, photophobia. So, I am talking about keratitis, right, any keratitis, photophobia. What is photophobia? All of you know this, intolerance to even a normal light. Right? That is, if you want to write, note down, intolerance to even normal light is photophobia. And when you are not able to tolerate, you close your eyes, and that is what is called blepharospasm. And after blepharospasm, SPASM. Okay? Blepharospasm and discharge in the eye, and of course, diminution of vision. Hazy vision and diminution of vision is another important feature. Take it. So, this will fit into all types of keratitis. Now, before I move further, what are the types of redness in the eye that you have to know? So, one type of redness is conjunctival congestion, and second type of redness is called corneal or circumciliary congestion. Ciliary congestion or circumcorneal congestion. It's all around the limbus. We call it ciliary congestion. Okay. So, let us understand that when the branch blood vessels of the conjunctiva, this is what is conjunctival congestion. This is congested, we call it conjunctival congestion. It's written anyway. Okay? So, these are generally branched away from the limbus, and it is mainly seen either along with ciliary, or if it is only conjunctiva, then it is due to any conjunctivitis. Whenever there's only conjunctival pathology, you're going to get only conjunctival congestion. But in serious pathologies like any keratitis, glaucoma, uveitis, we will get ciliary congestion. Okay. So, ciliary congestion are parallel blood vessels. These are deeper ones, deeper and parallel blood vessels, parallel to limbus. This is what is ciliary. So, what should I write for the keratitis there? What should I write here? That which type of redness? It is the ciliary congestion which is going. Of course, I can get conjunctival, but primarily it is the ciliary congestion that I am going to get in keratitis. Okay, so once we know this common presentation, we will now talk about bacterial keratitis. Now we can give the heading bacterial keratitis. Okay, one more thing let's discuss before going to the bacterial is, you all know that cornea is generally, of course, avascular. Any inflammation and keratitis in the cornea can also lead to corneal vascularization, and this is what is called pannus. Okay, so this is nothing but superficial vascularization in the cornea, which is called pannus. So this is another sign that you have to know regarding the congestion. One was conjunctival, one is ciliary, and one what is pannus. This you should also be very familiar with. Okay, talking about bacterial keratitis, first question is, what is the most common etiological? So, first we will learn, of course, the bacterial keratitis or bacterial corneal ulcer. Etiology. This is an exam question. What is the most common etiology? Most common we will always answer is Staph aureus. But if it asks you, the question says, most common bacteria in India. If this is mentioned, our answer will change, and now we answer Staph epidermidis. It is Staph epidermidis. Right? Okay. And another important thing, after LASIK surgery, we all know LASIK we will cover in the optics chapter, laser in situ keratomyelitis. So, after this refractive surgery, what can be the most common organism which can infect? Now, you are going to answer is atypical mycobacterium. Okay, atypical mycobacterium, and that is M. kiloni. Okay, so this is about etiology. There's one more thing. They've asked you which bacteria, I'm just covering all the questions here, which bacterial infection can lead to corneal perforation within 48 hours. So, corneal perforation within 48 hours. Within 48 hours. What will you answer now? You should answer Pseudomonas. Okay. Another question. Another question is about which bacterial infection resembles a fungal keratitis in presentation, like the ulcer is dry and rough like a fungal infection. So, this was also a recently asked question. You should answer which bacterial infection resembles fungal? Resembles fungal, that is your answer is nocardia, isn't it? So, we answer nocardia. Right. So, this is also a dry rough ulcer. Then another thing is, what can be some other causes? We have to also mention here about streptococcus. Okay. So, streptococcus pneumoniae, or what is also called pneumococcal infections, we see they are invariably always associated with hypopion, right? So, when it is always, so we can say this streptococcus pneumoniae, there are two questions they have asked you here, which is also called pneumococcus, streptococcus pneumoniae or pneumococcus. Okay. So, the question, these are the two questions they have asked you. First, it is also called, because it is always associated with hypopion, we call it hypopion corneal ulcer. It is also called hypopion corneal ulcer. Second question, it progresses in a serpentine manner. What do I mean by that? If this is the cornea, the ulcer is going to progress in a serpentine manner like this. Hence, we call it ulcus serpens. Okay, we will learn this. We also call it ulcus serpens. So, it's a simple chapter. It's mainly factual. You have to learn it with me. Okay, once we know this, we come to clinical features. Of course, it is the same. I am just going to write like this, and you should remember what are the things I have taught you. All the presenting feature of any keratitis: pain, redness, photophobia, blepharitis, sparse, discharge. and diminution of vision. Okay, once we know this, what is the on-examination finding? So what do you see on examination? What we see, number one, is of course, there will be congestion, which can be both ciliary and conjunctival. And what we see is an ulcer. If I stain this ulcer, it will be fluorescein stain positive. Any breach in the epithelium is fluorescein stain positive ulcer. Can we remember this? It can also be associated with, let's look here. Apart from this, you can mark it in your diagram here, hypopion. What is hypopion? Pus cells. Now, this is an exam question here in a bacterial keratitis. It is always a sterile hypopion. Okay, it's always a sterile hypopion. So, what you are seeing here is sterile hypopion. You are seeing the corneal ulcer. You can even see the corneal edema and Descemet's folds. Because of the stromal edema, there can be one is, I can see there is a haze which is stromal edema. There can also be, though it is not clear here, we can get Descemet membrane folds, and very important, every keratitis is associated with uveitis. So, you will get the features of anterior uveitis as KPs, right? We can see some keratic precipitates, right? Okay, so let's draw this together just to simplify your life. On examination, we always make a drawing here. So, we make an ulcer. This is the cornea, the pupil, right? This is done. These are the lids. So, we'll draw here. This is fluorescein stain positive ulcer, right? Fluorescein stain positive ulcer. Let's make it green. Fluorescein stain positive ulcer. What else we learnt in the findings? Let's revise. We learnt about hypopion, which is exam question always a no bacteria, only pus cells, sterile hypopion. What else we will learn? We talked about stromal edema, Descemet's membrane folds. Because of that edema, you can get this. And of course, keratic precipitates and all the signs of anterior uveitis. Okay? So, these are the features and on examination findings of a bacterial keratitis. Now, this ulcer can have three progression. Either when you are treating, it heals and it forms a scar which is called corneal opacity. Second, what can happen? It can cause thinning of the cornea and perforation. And third, what can happen? It is so virulent, it eats up the whole cornea. That is sloughing corneal ulcer. Okay? So, let's talk about what can be the three courses or types of ulcers. One is perforating, one is localized, and one is sloughing corneal ulcer. One by one, when you say perforating, what is happening here is corneal thinning. And when there is a corneal thinning, that leads to perforation. But think yourself, if there is a perforation, aqueous is going to leak out. And what happens immediately from the behind iris will come and seal that perforation. And when the iris sees the perforation, this is what you call leukoma adherens. So, they have asked you this as an exam question, that leukoma adherens is a feature of, we answer, perforating corneal ulcer. So, leukoma adherens is a feature of perforating corneal ulcer. Okay, what is localized here? Localized means I am treating and it heals. And when it is going to heal, it is going to lead to corneal opacity. We will talk about the different types of corneal opacity. So, this is localized. What is the third type? Third type is a sloughing. This is due to infection by very virulent organism. Okay, we learn like this, very violent organism. It eats up the whole cornea, but that doesn't mean that the area will be open. It is simultaneously replaced by inflammatory exudates. And when this is replaced by inflammatory exudates, write down please, this is what is called pseudocornea. Okay. So, again an exam question, pseudocornea is a feature of, we answer, sloughing corneal ulcer. Let me continue here. If there is a pseudocornea, if you will learn in sclera chapter also, it is a weak cornea. It can lead to ectasia, and that will be, it is leading to what you call anterior staphyloma. That is leading to anterior staphyloma. And when we were talking about perforating corneal ulcer, which bacteria? I think I just mentioned it. We are talking about Pseudomonas. Why Pseudomonas is more prone for causing this? Because it is actually releasing exotoxins which are collagenolytic. Okay. So, these exotoxins are collagenolytic and therefore, you can get a perforating. This is one of the commonest cause that you have to know, collagenolytic. Right. Next, we talk about how to investigate. So, whenever you are investigating, we are talking about micro. Of course, when you are talking about the investigations related to cornea, how could I forget? Apart from all the lists that you have talked about, pachymetry, we have talked about corneal topography, we have talked about corneal tomography, keratometry, specular microscopy, aesthesiometer. What else? Of course, don't forget microbiological investigations, that is staining and culture. If you want, you can write it in that list as well. So, when you talk about microbiological, you have to first get the specimen, right? So, how you can get it? For investigations, of course, we can go for corneal scraping. So, if there is any bacterial keratitis, you want to see what is the cause. The scrape, or you can get it either from a corneal scraping. Corneal scraping is generally done with Chimera first. You have to know this Chimera spatula, okay? So, this is mainly done with a Chimera spatula. Ideally, should be done with this only, or I can just get a conjunctival. From the conjunctiva also I can get a conjunctival swab, right? Or what is the third thing? Sometimes patient is using a contact lens, so I can get some specimen from the contact lens cases as well. These are the sources I can use. Okay. So, once I get this, now I have to subject it to, we all know, that is staining and culture. Talking about the staining part, how do you stain? If you are doing it for the bacterial keratitis, of course, we are talking about gram stain and Giemsa stain. So, we will note it down here, gram stain, Giemsa stain. Anything else we want to write? AFB. Okay? And AFB, this is mainly acid fast. This stain is mainly used for atypical infections, or you can say Mycobacterium, Nocardia, which are not common, of course, but if you are suspecting this, you should do the staining, right? So, Mycobacterium or Nocardia. Okay, I hope you are noting down along with me. Right. When we talk about the culture again, you know, we are talking about blood agar, chocolate agar, you know. So, this is more of a microbiology here. So, culture, you can just note down, we have to complete the list. So, we are talking here. You heat it, you can turn it into a chocolate agar due to lysis. And of course, one more again for Mycobacteria and Nocardia, you have to know is Lowenstein-Jensen, right? Lowenstein-Jensen culture media. So, this is again for these two. And if I am talking about one more that I can learn, so let us number it 1, 2, 3. Number 4 is Propionobacterium acne. Propionobacterium acne is anaerobic, and what you can use here is cooked meat broth. Okay. So, we will write one point here, cooked meat broth can be used for anaerobic bacteria. In the eye, mainly we are talking about Propionobacterium acne. Propionobacterium acne, ACNE. Okay, I hope you can read it. Did I write it again? This is acne. Right. So, give the heading treatment of bacterial keratitis. First point that you will see, notice, if I am going to go for a broad spectrum, that is empirical monotherapy, then which are the drugs I can use? Of course, best is where the ocular penetration is best is moxifloxacin. Okay, quinolones, of course, and quinolones we prefer quinolones, no doubt, and the best would be moxifloxacin. I can go for Gatti also, but I am also most happy with moxifloxacin. Just know the names. It can be Gatti floxacin, it can also be becifloxacin. Let's prefer moxi, right? Okay. Otherwise, second option is I do a culture sensitivity, and according to that, I am going to treat. Suppose it's still, even after culture sensitivity is not responding, I can go for concentrated antibiotic eye drops. So, when you say concentrated antibiotic eye drops, it is fortified antibiotics. So, this becomes a duotherapy. I need for both gram positive and gram negative. So, I call it a duotherapy where I go for fortified, which is concentrated antibiotic eye drops. Fortified antibiotic eye drops में what are we going to write here? Of course, one combination can be cefazolin, which is concentrated to 50 milligrams per ml, and gentamicin, which is actually concentrated to 15 milligrams per ml. Right? So, either we go for cefazolin or gentamicin, 50 milligrams or 15 milligrams per ml. There can be another combination. I can also use cefuroxime instead of cefazolin. So, cefazolin, or can we put it just like an oblique here, or we can also use cefuroxime. Okay, I have given you the concentration of cefazolin. Okay, that was one thing. Then we talk about, of course, along with that, I am not going to keep putting eye drops at night. So, if the infection is severe, we put it more frequently, 1 hourly, 2 hourly, then we slowly taper off to more longer intervals, 4 times a day and so on. Anyway, what is the next thing? What you do at night is you put an ointment, right? So, we will write here that this also, that antibiotic ointment at night. And suppose the patient is not very compliant, then I may have to opt for subconjunctival injections of antibiotics. Right. What else I can do for healing of the ulcer? For healing of the ulcer, I will give oral anti-inflammatories. Can I get steroids to control the inflammation? No. Any infective pathology, steroids is a big no. It will increase the infection. Okay. And I can go for vitamin A and vitamin C. Is this enough? Don't you remember? There can be associated uveitis, isn't it? Again, I can't give steroids, but for this associated uveitis, what else I can do is go for cycloplegics and anti-inflammatory. So, I give cycloplegics here. And of course, we can add here that for healing of the ulcer and epithelial growth, you can always give lubricating eye drops. Right. Once we know this, is there any role of a systemic antibiotic? If you suspect Neisseria gonorrhea or Neisseria meningitis, because then the involvement systemic spread is a chance, right? So, write down number 10. If we are suspecting Neisseria gonorrhea or Neisseria meningitis, in this case, or you can also write one more, Haemophilus influenzae. Then we should start with, mainly we are talking mainly in more common in children, of course, but we should start with systemic antibiotics. Right. And the last thing that we can add here in our treatment part, if there is any corneal thinning. So, if there is a corneal thinning and you feel, okay, anytime the patient, it can lead to perforation, you should prefer that drug which is saving the collagen, which is anti-collagenase has anti-collagenase activity. So, which are the antibiotics with anti-collagenase activity? Doxycycline, okay, and tetracycline. So, anti-collagenase effect, we can start with doxycycline or tetracycline. Right, all of you? Okay. So, that was about treatment of bacterial keratitis. Now, you have done everything, the ulcer is still not healing. What are the measures I can take? So, our next heading will be management of a non-healing ulcer. So, when the ulcer is not healing, a very common sense that you have to just remove the necrotic tissue from the periphery of the ulcer. What is that called? We call it debridement. So, number 1 is debridement, which is nothing but, if this is the corneal ulcer, we are removing the necrotic tissue from the periphery of the ulcer. Right? This is what is debridement. You can do it even with a sterilized cotton bud. So, this is your debridement. What is the second thing I can go for is chemical cauterization. What is chemical cauterization doing actually? Chemical cauterization is acting as a local antiseptic. So, I am putting this at the ulcer area. It acts as a local antiseptic and it will start enhancing the healing process. What are the chemicals we use is your exam question. Your first answer has to be TCA, trichloroacetic acid, and the second can be carbolic acid. Okay, so first is which one? Trichloroacetic acid. Okay, what else I can do to enhance the healing of the ulcer? I can use a bandage contact lens. Bandage contact lens is nothing but high water content soft contact lens. Okay, so it's a high water content soft contact lens. So when you say high water content soft contact lens, I hope you know what are the types of the contact lens. Contact lens can be of two types. Either, of course, theoretically it is three types: soft, semi-soft, hard. But hard is obsolete, so we learn it soft and semi-soft. What is semi-soft also known as? Rigid gas permeable lenses. And we will write this in the optics chapter also, but here I just told you so that you should be clear. Anyway, what next I can do is that suppose in spite of all these measures, now of course to enhance the healing I am giving lubricating eye drops, that I have already told. But if it is not healing, debridement, chemical cauterization, bandage contact lens, nothing is working, go for some surgical procedures. What is the surgery I can do? I can go for amniotic membrane grafting. So what you are doing is you are just covering that area with this so that it helps in healing. It is not disturbed by blinking of your lids and so on. Or mucous membrane buccal, mucous membrane grafting. These are the two options. Sometimes if the defect is still persistent, if still there is a persistent epithelial defect, now what else we can do is go for Gunderson's conjunctival flapping. Gunderson's conjunctival flapping. Okay. So when you say Gunderson's conjunctival flapping, what you are actually doing here? We are covering the whole corneal area. So there is an ulcer here, not healing. You are covering the whole thing with the flap of conjunctiva. Okay. So this is total covering it. This is what is called Gunderson's conjunctival flapping to help to heal the ulcer. Right. That was grafting. This is flapping. Okay. Once we know this, let's see another situation. We have a patient with impending perforation. Right. Matlab, there is a lot of corneal thinning and when I look at it, I feel, oh my God, anytime it can perforate. So let us note down what is the management of impending perforation. Management of impending perforation. So how to see that, okay, it doesn't lead to perforation? Common sense. Start giving anti-glaucoma and decrease the intraocular pressure. Further decrease, whatever, even if it is normal, further decrease the intraocular pressure. Secondly, what we can do is, and corneally at the ulcer area, you are going to put cyanoacrylate glue. Okay. So we put cyanoacrylate glue. So it's nothing but like a Fevikwik, but a sterilized one, right? So this will help in preventing any perforation. And suppose there has been a perforation, how do you treat that? So first of all, let's first discuss the three measures. One is we start with this, and the third one, okay, note down, we can use bandage contact lens which can act as a tamponade and prevent perforation. But suppose it's already done. If I talk about perforation, how will you treat? Depends. Less than 2 mm cyanoacrylate glue, more than 2 mm because it's due to the bacterial ulcer. Okay, so you will say therapeutic keratoplasty, right? We'll talk about different keratoplasty, full thickness and lamellar. So whatever it is, when the indication is treating the corneal ulcer, we call it therapeutic. It's all about indication why we are doing a keratoplasty. Okay, so kindly correct that. Okay, so that was about bacterial keratitis. We next talk about is fungal. When you talk about fungal keratitis, what is the other name of fungal keratitis? We also call it keratomycosis. So fungal keratitis, let me start with few important questions here. Let us see the first question. Let's make a cue here. We are talking about important questions. First question is, Which is the most common fungus infecting cornea? You have to answer Aspergillus fumigatus. Right? If this option is not given, the next best option is Fusarium. Okay. Next question. Next question is, why will you get a fungal keratitis? This has been a repeated question. We will answer trauma by vegetative matter. Trauma by vegetative matter. Vegetative matter means or organic matter. That means by a leaf or a twig. So this is what we mean. Next question. Signs are more or symptoms are more? We are comparing with bacterial keratitis. Please note down, signs are more than symptoms compared to bacterial keratitis. Now, why? What does this mean? If a patient is coming to my OPD and he is shouting out of pain, I see a very small ulcer. This is bacterial. But he comes to my OPD, he is not shouting of pain. I see a big ulcer on the cornea. So, sign is it's a big nice ulcer, but he is not shouting of pain. This cannot be bacterial. It has to be fungal. Got it? So, fungal signs are more than symptoms. Right. Of course, another cause, if you want to add down the another cause, it can be low immunity. Mainly it is trauma by vegetative matter that you have to answer. Otherwise, another thing is, of course, any low immunity can lead to fungal infections. We all know this. If they ask you most common fungus infecting lids, now what will you answer? Then if it's most common fungus infecting lids, they have asked you this once, that's why I am discussing. We answer Candida albicans. So once we know this, we can very quickly also revise about the details types of the fungus if you talk about the fungal infections. So broadly, we can say that it can be either a yeast, right, and or filamentous, right. You know more details, but here a very quick revision here. These are filamentous septate. I am talking about the corneal infections. Here that is septate and it is non-pigmented. This is what is you have learnt Aspergillus, and which is the most common cause. It is not Aspergillus niger, it is Aspergillus fumigatus. And secondly, so fumigatus is important, you should know, and second would be Fusarium. Done? And when you talk about the yeast type, this is what is yeast. Mainly the infections are more in temperate region, and here we are talking about Candida albicans. Okay. Now we talk about, once you know this, we next talk about is what are the clinical features of a fungal keratitis. So when you say fungal keratitis clinical features, can we again revise the 5 to 6 fingers here? Right? Same pain, redness, photophobia, blepharospasm, discharge and diminution of vision. Okay, we come to on examination. We will make a diagram to learn this on examination. What do you get on examination? First, let's have a look. This is your fungal keratitis, right? So, what do you see here? We are seeing this dry rough ulcer and the projecting ends are called hyphae, right? So, these projecting ends are hyphae. And the ulcer typically is described as a dry rough ulcer. Okay, let's draw together. Okay, so what is the first point? That the ulcer has got a dry rough look. That is our first point. So, dry rough look. Our diagrams are our savers, okay? Picture memory is a basic role of picture memory. Actually, it's a very big role of picture memory, and therefore, I keep stressing to you all that make all the diagrams. And you know, once in the last minute revision, it is these diagrams which are going to help you. So, please draw together with me. These are dry rough look. This is an ulcer. We can again put here, these projecting ends are hyphae. Of course, you can get a hypopion, and this time what is this hypopion? This is exam question. It is unsterile. So, do you understand? When it is unsterile, it is in the anterior chamber. That means fungi can actually penetrate the whole cornea and go into the anterior chamber. And when we were talking about the bacteria which can actually penetrate intact epithelium, we were not talking about whole cornea. Why I am repeating? Because it has been a frequent question from you all, and it has been one of the common mistakes. That's why I am telling you this. Okay, so we note here it is unsterile hypopyon. Right? It is unsterile hypopyon. What else? Very important, there are smaller lesions away from the main lesions. Put a double Q here, repeated question, satellite nodules. So see how many questions I've asked, right? So satellite nodules. And one more, very important, Wesley's ring. Wesley's ring is nothing but an immune ring. Here we will learn Wesley's ring. This also has been a Q. We can put a Q here. So this immune ring, which is consisting of the immune cells, it is can be a feature of few bacterial infections, can also be seen in viral, but more commonly in fungal. So both are all are given, you have to answer fungal, right? Okay. And of course, apart from this, I have again taught you, you can get KPs because any keratitis can be associated with uveitis. So KPs and all the signs of anterior uveitis may be present because any keratitis may be associated with uveitis. Okay? Okay. Once we know this, we next talk about investigation. Again, when you talk about the investigations, it has to be microbiological investigation. You are taking out the sample in the same way, corneal scraping, right? Generally, it is corneal scraping. Now, apart from that, you can even directly visualize the fungi. Okay, so we divide it like this, that we will either going for the staining and culture after corneal scraping. Let's write like this. We can go for the corneal scraping and then go for staining and culture. Okay, right? Now, when you say staining and culture, or you can directly look at by confocal by microscopy. Directly you can see the hyphae. So, write down confocal by microscopy. This will help you for direct visualization of hyphae. Okay. So, if you are not doing a confocal by microscopy, you are taking this specimen sample. Which is the commonest stain we use is, we all know 10% KOH smear. And when you see it, you can see it either in the light microscope or fluorescent microscope. This can be seen. And what is the second? Either I am seeing it in light microscope or in fluorescent microscope. Okay, even if you don't write it, it's okay. What is the second? It is Gomori's methamine silver stain. What is the full name? It is called Grocott. Grocott Gomori's methamine silver stain. Okay, methamine silver stain. Right. This is the stain. This is how you are staining a fungus. Coming to what can be some other names? Calcofluor white, even gram stain and Giemsa stain can be in the list. So, we will note it down that we are talking about stain here. So, continuing with that, there can be, we can write calcofluor white. Calcofluor white you are also going to learn in acanthamoeba keratitis, right? Then gram stain and Giemsa stain can also be used and it's in the list. Coming to the culture, we all know we are talking about SDA and PDA. SDA is Sabarod's dextrose agar. Okay, so we write the culture here. Culture media, let's learn the culture media. We'll write here Sabarod's SDA, Sabarod's dextrose agar, and what is PDA? Potato dextrose agar. Right? Okay. So, this is most commonly used. Now, of course, keep in mind when you're doing a culture, normally in a bacterial culture, reporting is done after 7 days, right? After 3 days, I mean to say. But if you are doubting a fungal infection, you have to report after 7 days. Okay. So, please note it down. If the reporting is, so for a bacterial it is after 3 days, but here reporting is in 7 days. Sometimes another, if you want to complete the whole list apart from culture media, directly visualizing, doing this, we can do a PCR, number 3. And sometimes if nothing is working, we may need to go for corneal biopsy. Again, this is more like completing the list. They haven't asked you all this. Okay, talking about the treatment of fungal keratitis. A repeated question, which is the choice, drug of choice? Do we all know this? What is the drug of choice of fungal keratitis? We will answer natamycin. Okay, so drug of choice, make a cue all of you. Drug of a choice is natamycin. How much percent? 5%. You start with natamycin. Initially, you should give very frequently, almost 1 hourly for 2 days, right? And of course, even at night, we prefer to give it along with nystatin eye drop. Okay, so at night also 2 hourly with nystatin eye drops. I mean to say nystatin eye ointment. I'll correct here. Nystatin eye ointment. Now you started with this, and slowly after 2 days you may taper the frequency to 2 hourly. But you will first see whether it is responsive or not. Hai na? Then only you can do this. So you have started something like this aggressively. Now there are 2 options. Either this is responding. If it is responding to the treatment, then we continue, just taper in 7 days. But suppose it is not responding, now you add something more, isn't it? We add voriconazole 1%. Okay, so we add 1% voriconazole, or another option can be 0.5% amphotericin B or 0.5% amphotericin B, right? And apart from natamycin, there can be another option is econazole 1%. But of course, drug of choice kya bataya? Natamycin. Okay, so we can also note down the second drug that can be econazole 1%. But yes, drug of choice is always natamycin. Okay, so in severe cases, what you do? So this is one thing in any fungal keratitis, we are following this. But sometimes if it is very severe, in severe we will add something more here. Then in severe cases, we have to start systemic antifungals. Okay, so when you are giving a systemic therapy, what are the drugs I can give? Is, of course, we all know about fluconazole tablets, fluconazole. So fluconazole, or you can go for is voriconazole. So fluconazole and voriconazole, what is very important is you have to monitor the liver function test. Okay, so monitor the LFT and then give for either fluconazole or voriconazole. So this may be needed in severe cases, right? Okay. Secondly, another option for systemic is I can also go for subconjunctival injections of fluconazole. That is another way. I admit, of course, this is not systemic, this is a local, but this may also be needed along with the eye drops. Another thing is systemic may either I am giving systemic in severe case, or I am starting with subconjunctival in severe case, or sometimes I am giving intracameral. Intracameral means inside the anterior chamber. And of course, here we have to use a preservative-free drug, right? And what we can use here is again either voriconazole or amphotericin B. Okay, so intracameral, either I use voriconazole or amphotericin B. I hope I was clear and not confusing to you all. Very quickly I am repeating, if the fungal infection is very severe, I can either go for add some systemic therapy with fluconazole or voriconazole, or I can just go for subconjunctival injections as well for fluconazole or intracameral injection, right? Another exam question, another drug which can be used as an antifungal is silver sulfadizine, which you use in burns and all, okay? So this was one of your INI-CT question. So please remember, silver sulfadizine can also be used as an antifungal. Okay. And sometimes it's a very resistant infection. So this is out of the way one name that I'm telling you. Just remember, if it is a recalcitrant infection, in that case, one new drug is caspofungin. Just know the name, no, doesn't seem like anybody will ask. ये तो हो गया आपके antifungals. What else? Isn't there an associated uveitis? Yes. So, please note down, you are going to treat the treatment of uveitis. We will start with anti-inflammatory and we are going to give cycloplegics. So, we will give anti-inflammatory and cycloplegics. Okay. What else? Then we have to also think about if is there any thinning. If there is a thinning of the cornea, again we have talked, you are going to use the drug which has anti-collagenous effect, that is either tetracycline or I can go for is doxycycline, right? And if there is a perforation, we may need a therapeutic keratoplasty. Therapeutic keratoplasty. Okay? No suturing. Of course, that was a mistake. That's only in case of corneal trauma. Okay, so maybe required is therapeutic keratoplasty. Okay, so once we know this, that was about your fungal keratitis. One important thing, I've been telling you again and again that in any infective pathology, there should be no steroids because it will aggravate inflammation. So there are two rules. I want you all to put it in the box. What are the two rules which we should never break? In any infective pathology, infective corneal ulcer, what are the things, what is the rule which we have to follow? Any infective corneal ulcer, two rules that we will not break. Number one, no steroids. And number two, no pad and bandage. Remember this, no steroids and no pad and bandage. Correct? Okay, so next heading is viral keratitis. Which virus? Of course, when you're talking about a corneal infection, we are talking about herpes, isn't it? So, first question is, which is more common? Is it herpes simplex or zoster? What will you answer? It is the simplex which is more common than herpes zoster ophthalmicus, right? So, another question, herpes infection is one of the most common infective cause of corneal blindness in a developed country. So, this is just a piece of information that you can keep in mind, that what is the most common infectious cause, infective cause of corneal blindness, but we are talking about not India, we are talking about developed countries. Then our answer becomes developed countries. Then again we are talking about viral keratitis, herpes, okay, herpetic eye disease, right? So, this is another just a piece of information that you should know. So, it is most common infective cause of corneal blindness in developed countries is herpes infection. Okay. Then we talk about next is, that is, or you can say herpetic herpes or herpetic eye disease can be said, right? Okay. Let me ask you another question. Which is the pathognomic feature of viral keratitis? If this is the question, pathognomic feature. What is your answer? Many of you answer me, ma'am, it is dendritic ulcer. No. Dendritic is a feature of simplex, it's not a feature of zoster. So, then you need to answer pathognomic feature, we will answer is decreased corneal sensation. Okay. So, decreased corneal sensation. What can be other causes of decreased corneal sensation? Sorry for this. Let's write other causes. Okay, revise with me. What was it? Leprosy, number one. Apart from viral keratitis, then I said diabetes, then I said chronic degenerative disorders, diseases, conditions like in the cornea, like you can get it in absolute glaucoma, right, thysis bulbi, and so on. Band-shaped keratopathy. इसके अलावा section of trigeminal, because that is the nerve supply, so section of the fifth nerve. Is it okay? Yeah. You want to write here? You can also write band-shaped keratopathy, right? Band-shaped keratopathy, comma के लिख लो, and section of trigeminal. These are the causes of decreased corneal sensation. Okay. So, once we know this, we next talk about is herpes simplex, right? So, herpes simplex, can we revise it here first? That herpes simplex is S1 and 2. What is simplex 1, which is causing infection? Above the waist. When you say above the waist, we are talking about the face, eye involvement, face involvement and lips involvement. Okay. So, these are the areas which get affected by HSV1. HSV2. HSV2 is below the waist. Mainly we are talking about genital infections. That means when we are learning herpetic keratitis, we are talking about HSV1. But now pay attention. HSV2 is the cause of conjunctivitis, which is neonatal conjunctivitis, because during the birth the child gets infected while in a normal delivery through the birth canal. So, you have to know this, that in neonatal conjunctivitis, this is important, it has been asked. क्यों लगाओ? Neonatal conjunctivitis, it is mainly HSV2. The cause is HSV2. Now let's go back to HSV1, which is above the waist. Now this, you have to know, there is one primary infection first, right? So this primary infection is not causing any severe eye involvement. This primary infection is mainly a self-limiting infection, which is, of course, the medium is through droplet, and it's a droplet infection, but it is self-limiting. Okay. Now, what it is causing is maybe some blepharoconjunctivitis, but corneal involvement is not severe, maybe mild corneal involvement, but primary infection is basically causing blepharoconjunctivitis and mild corneal involvement. What happens next? This becomes dormant in the trigeminal ganglion. So when it gets dormant in trigeminal ganglion, now when it is getting reactivated, the reactivation is finally leading to a recurrent infection. So one is primary infections, second becomes your recurrent infection. And it is this recurrent infection which is causing a severe corneal involvement and keratitis. Okay. So in this time primarily it is the corneal involvement. Got it? Okay. Clinical features. So how will it present? Same 5 features? 6. Okay. So pain, redness, photophobia, blepharospasm, discharge, and of course it's viral, so watery discharge. And what else do you get apart from this? Of course, what point you have to remember with me here, that pain, when I am saying, think with me, is still a feature, though there is decreased corneal sensation. So please don't be in an impression that if the corneal sensation is less, there will be no pain. Okay, so pain is still a feature, right? Please keep this in mind. We come to on examination. On examination, what are the findings? Before we make the diagram, let's have a look. And how we are going to learn? This time our diagram would be like this. If you want, let's make it and then we will see this slide. We are going to learn like this. What are the epithelial involvement? What happens in epithelium? What happens in stroma? What happens in endothelium? All of you note down. Epithelium, stroma, endothelium. Okay, one by one. First is epithelium. When you look at the epithelium, what you see? Have a look. These are punctate lesions on the corneal epithelium. This is called superficial punctate keratitis, right? So this is your superficial punctate keratitis. It is in puncta form, hence the name, right? We can have a better look here. This is what is superficial punctate keratitis. And later what happens in the epithelium is ulcer formation, right? What is the ulcer? Dendritic ulcer, right? What is the ulcer? Again see here, dendritic. Why do you call it dendritic? I am not making it circular. It's like a branch of a tree. So we call it dendritic. What is the diagnostic feature of a dendritic ulcer? All of you, we will answer. What is the diagnostic feature? Look here. Dendritic ulcer has knobbed ends, isn't it? So we will not forget this. It has knobbed ends. It has knobbed ends. Right. If you are looking at a typical, can you see here we have stained with fluorescein? So this fluorescein stain is actually at the base of the ulcer. This is the base which is a denuded epithelium, and this stains with fluorescein. If I am looking at the margin of the ulcer, this takes a rose Bengal stain. This is again a typical thing, rose Bengal stain. Why? Because rose Bengal is staining dead cells and mucus, and these are virus-laden dead cells. Okay, that is why rose Bengal. This was your dendritic ulcer. And if by mistake you give steroids or you are not actually treating and it progresses, either way, then this can lead to geographical ulcer. Why we call it geographical? Because it is amoeboid in shape. This is your geographical ulcer. So all of you, another very important repeated question of your exam, we can note it here only, that steroids are contraindicated in dendritic ulcer. DU means dendritic ulcer. Why? Either it can lead to geographical or finally it can cause either lead to geographical ulcer or it can lead to corneal perforation as well. Okay, therefore it is contraindicated in dendritic ulcer. That was your epithelial involvement. We are going to write it in our diagram also. Let's keep listening first. Stromal involvement will be stromal necrotic keratitis, and then we come to endothelial. Okay, let's go back to the diagram. Okay, so can we note it here that epithelial involvement mein what did you learn? Number one was superficial punctate keratitis. Write in my way. Second you will write is, we will draw here dendritic ulcer which has knobbed ends. This is your DU and it can progress as amoeboid in shape. This is your GU. This is dendritic and geographical ulcer. Next we talk about stromal. Stromal involvement can either be, let me add here, direct infection, or it can be a manifestation of hypersensitivity reaction. What it leads is stromal necrotic keratitis. Right? And if it is a part of hypersensitivity reaction, we have an exam question. What type of hypersensitivity in stromal involvement of herpes simplex? You will answer, it is type 3. Right? So, it is type 3 hypersensitivity reaction. We come to endothelial involvement now. Endothelial involvement, let's learn together. Endothelium involvement, can you think with me? Main function of endothelium is what? Keeping the cornea in a dehydrated state. So, in endothelium involvement, there is endothelitis, but it is typically only on the central cornea. Got it? So, because only the central endothelial cells are inflamed and there is endothelitis, therefore, because it is all involved in a circle-like manner, we call it disciform keratitis. We call it disciform keratitis. Okay? And in disciform keratitis, when this is involved, definitely what you are going to get is a corneal edema, that we know. So, what you get here is corneal edema, but it is only central corneal which is affected. So, what is disciform keratitis? Endothelitis in a disc-shaped manner. Correct? Okay. Again, this can either be a direct manifestation of a direct infection, or it could be just a manifestation of hypersensitivity reaction. Another exam question, endothelial involvement, which hypersensitivity? We are going to answer type 4 exam question. So, this is your type 4 hypersensitivity reaction. Okay. So, we next talk about, after this, after we have learned these features, we will talk about investigations. Right? Again, think with me, majority of the time when it is a viral infection, the investigation is clinical. So, this is majority of the times we don't need any, it is the clinical diagnosis which is most commonly done. Of course, if you want to complete the list, you can mention that we can go for PCR, which is a definitive investigation for any viral infection. Another one point that we can note down, that if you go and we are examining it under the GIMSA stain, what you see is multi-typical multinucleated giant cells. Okay? Multinucleated giant cells. Right, all of you? Okay. Is there any role of any serological investigation here? So, keep in mind, generally the corneal involvement only happens in as a recurrent infection, and there is no role of any serological investigations if the infection is recurrent, right? Okay. So, once we know this, how do you treat a viral infection? We all know antiviral may we give acyclovir. So, number one, topical acyclovir ointment. How much percent? 3% acyclovir eye ointment, which is given 5 times a day, right? So, this is one drug which is available only in ointment form. There is no eye drop form. Do you know about any other drug which is only ointment form? Tetracycline. How much percent? Just in the bracket as an additional information, that if you want to know that tetracycline is 1%. Which is another ointment that you learn 1%. Don't forget atropine. So, this way you can learn the percentage of 3 ointments: tetracycline, atropine and acyclovir. Good. What is the other option apart from acyclovir? We can go for 0.15% of gangcyclovir. So, write down 0.15% gangcyclovir gel can also be given. Gel can be used. Apart from this, you should be familiar with some names of the other antiviral drugs like trifluorothiamidine, right? Vidarabine and a very old one, now not used so much, idoxuridine. Why not? Because there is a lot of resistance now towards this drug. Idoxuridine, it is N. Doxuridine, right? Okay. So these are the antivirals, but this is all topical, of course. Apart from that, I have taught you that any infective pathology, we don't give steroids. But there is a situation. If there is deciform keratitis, okay? So, deciform keratitis, that means only this part is involved as a hypersensitivity reaction with normal stroma and normal epithelium. Okay? If there is only deciform keratitis, which is hyper. Now you got it? Then you may give steroids, but under antiviral cover. So then we give steroids, but what do you mean by a cover? Cover means if I am giving the therapy from, suppose I am giving antiviral from this to this time span, I can give steroids only after starting antiviral, and I have to stop the steroids before stopping antivirals. Okay? So, antiviral, before starting, I have started antivirals, and after stopping the steroid, I am still continuing with the antivirals. That is what is called antiviral cover. Okay? So, that was another point in the treatment of viral keratitis. That is, you may give topical steroids if there is only, what did I explain you? Deciform keratitis with normal stromal involvement and normal epithelia. What else you have to do? Of course, associated uveitis, you have to treat with cycloplegics. Every time we say this, for anti-uveitis, we are giving cycloplegics. Any inflammation in uveitis can lead to increase in intraocular pressure. Now, there is an interesting point here. Management of increase in intraocular pressure, of course, you will give anti-glaucoma. But what is important is avoid prostaglandins. Okay? Why do you avoid prostaglandins? Because it is actually promoting herpetic activity. So, that's an important point. Let's note down. Avoid PG analogs. Even if I have to give anything to control the IOP, I should avoid PG analogs as it promotes herpetic activity. It promotes herpetic activity. Now, generally the systemic therapy is not required in a simplex keratitis. Topical is enough. But if you have to give a systemic antiviral, what will you give? So, if there has to be a systemic treatment and systemic therapy has to be given, it is generally oral acyclovir. Oral acyclovir, there are two ways of giving. Either we give a therapeutic dose. This we do if there is a stromal involvement or endothelial involvement, we go for therapeutic dose. Okay? And if there is only epithelial involvement, right, then we will just give a prophylactic dose. Now, what is that? Let's understand. When you are giving a therapeutic, it is mainly we are talking about simplex. Okay? So, in simplex, we are talking about the simplex keratitis. Generally, I am saying we don't even need to give any systemic. But if we are needing to give, then for a therapeutic dose, it is 400 milligram tablet, which is given 5 times a day. And in a prophylactic dose, it is given 400 milligram is given twice a day. That is BT. Or other option could be, this was acyclovir. Another thing which can be given as a prophylactic apart from acyclovir, you may also use valcyclovir. Valcyclovir, if you are giving prophylactic, it becomes 500 milligrams and given only once a day. If you don't want to remember valcyclovir, forget it. Right? But this much you should know. The topical treatment should be thorough. Okay. We next talk about is herpes zoster ophthalmicus. Okay. So, do we all know about varicella zoster virus? Right? This is caused by varicella zoster. Varicella zoster, the varicella is causing what? It causes chickenpox. Okay. This is a quick revision here. And when you say zoster, the zoster is herpes zoster. And herpes zoster infection is what is called shingles. You all know this. This is what is called shingles, right? So now we have to learn in detail about herpes zoster ophthalmicus. What are the three components of herpes zoster ophthalmicus? We will learn there can be skin involvement, there can be eye involvement, or trigeminal neuralgia. The or nahi and, okay? You will get skin involvement, eye involvement, and trigeminal neuralgia. So let's have a look. So what do you see here? The skin involvement in herpes zoster. This is along the dermatome of trigeminal nerve. So this all involvement is along the 5th nerve dermatome, right? So we will keep this in mind that this is, and it will not cross the midline. That is another important feature. Along the dermatome of 5th nerve, and it doesn't cross the mid. So these vesicles that are formed, these are mainly vesicular lesions, or vesicles are formed initially. Then they ask you a very important question. What is Hutchinson's rule? Okay. So make a cue all of you and note down what is Hutchinson's rule. Hutchinson's rule kya bolta hai? Hutchinson's rule says that you just saw the skin lesions. If these vesicles are on the tip of the nose, so if the tip of nose is involved, it is a rule that eye will be involved. Okay, this is what is, that means there will be keratitis. This is what is Hutchinson's rule. Make a double Q actually. And interesting thing, the vesicles on the tip of the nose is what is called Hutchinson's sign. That is called Hutchinson's sign. So what is Hutchinson's sign? That is nothing but vesicles at the tip of the nose. Right. So once we know this, what is the main etiology of herpes zoster ophthalmicus? It is generally immunocompromised patients and elderly patients. Okay. So we will note down here that when you talk about HZO, what is the etiology? Give the heading. Etiology is number 1, if the patient is immunocompromised, or number 2, it is more common in elderly patients. We should also not forget that it can just be an early indicator of HIV. Early indicator of HIV. Right? Okay, we talk about the clinical features. So clinical features, again, let's learn like this, that infection can present in 3 ways. Either the acute infection, or chronic infection, or relapsing infection. Right? Okay, so one by one. First is acute. Okay, so give the heading acute presentation or acute infection. What are the things, how it can present? Let's draw a diagram and learn. It will become simple. From outside to in, let's start thinking. So this is pars plicata, pars plana, suspensory ligaments, this is the choroid, and this is the retina. Anyway, so outside to in, we will learn. First is your episcleritis. It can present as episcleritis or scleritis. Okay, so one is episcleritis and then scleritis. Number 1, number 2, right? Then of course it is presenting as keratitis as number 3, herpetic keratitis. Then uveitis, number 4, right? This way we can learn. We are talking about herpes zoster ophthalmicus, okay? That is uveitis. And of course, one very important is ARN. What is ARN? Acute retinal necrosis. This is acute retinal necrosis. Apart from that, it can also lead to, of course, cranial nerve palsies. Which are the nerves that can be involved? All 3, 4 and 6 can be involved. But most common cranial nerve is 3rd nerve. But we are saying most common cranial. If the question is most common nerve involved in zoster, what will you answer? It's an important question. Most common nerve involved in zoster. Now we will answer is frontal nerve. Okay. Then our answer will be frontal nerve. Okay. Okay. Now we have to learn about keratitis. Isn't one of it? The details will be for keratitis. Of course, clinical feature would be the same 5. 6 features that we have learnt. On examination, let's make a diagram here. What we see? Epithelial involvement. Epithelial involvement is seen as number 1, superficial punctate keratitis, puncta-like lesions on the epithelial layer with the infiltration of inflammatory cells. And secondly, what you see is, apart from this, punctate lesions, slowly it will lead to, does it cause dendritic ulcer? No. What it leads to is pseudodendrites. All of you, these are pseudodendrites, or sometimes we call it microdendrites. So, pseudodendrites or microdendrites. This is the epithelial involvement. Why do you say it's pseudo? No knob dents. It doesn't have any knob dents. That is why we call it a pseudodendrites. So, if you note down, okay, so this is pseudodendrites or microdendrites because of no knob dents. Please note this down. Let's have a look also. We'll see the slide shortly. Let me finish this. No knob dents. Right? And when you look at the stroma, what do you see? Circular lesions like this, which we call, this is important. Put a Q here, all of you. This is exam question. This is your nummular keratitis. So, we answer nummular keratitis. And when you talk about the endothelium, it is the same in endothelitis in a disc-shaped manner, which you call disciform keratitis, isn't it? So, this is your disciform keratitis. If you make these simple diagrams, you will never forget, right? So, that was about zoster keratitis. Let's have a look at the slides. Okay, before that, let me add one more thing. Apart from nummular keratitis, again, the same thing applies direct infection or hypersensitivity. In a hypersensitivity reaction, it can manifest as interstitial keratitis. Can we note this? If it is a hypersensitivity manifestation, it can be interstitial keratitis. Again, in disciform, it can be direct or hypersensitivity. So, again here write down that it can present as interstitial keratitis. So, first, as we just learnt, is superficial punctate keratitis. We have seen in simplex as well. These punctate-like involvement of the epithelium. Okay, what is the next thing involved after superficial punctate keratitis? We will answer. Second is pseudodendrites. Can you notice there are no knob dents here? So, this is what is pseudodendrites, right? So, pseudodendrites are mainly feature of zoster, okay? And of course, we just talked about nummular keratitis. These are the circular lesions which are seen in the stroma. This is nummular keratitis, okay? So, once we know about the keratitis part, the second thing is chronic. What about the chronic eye disease? Next heading is chronic eye disease. So, when you say chronic eye disease, in the zoster infection we are talking about, what are the findings? One very important is write down neurokeratitis, okay? Then there can be, this has been asked once, mucus plague. It is mucus plague keratitis. When there are mucus plaques, that is called mucus plague keratitis. How do you dissolve the mucus? I hope you all know we can use acetyl. And how does a mucus stain? Mucus stains with rose bengal, right? We will not forget this, rose bengal staining. And how you are going to treat? We have to give acetylcysteine eye drops to dissolve the mucus, right? So, mucus plague keratitis, make a Q. Right. Apart from that, of course, what next you can get is scleritis and episcleritis, and lastly, very important again an exam question, lipid keratopathy. Now, what is lipid keratopathy here? Lipid deposition on the cornea. Okay, irregular deposition of lipid on the cornea is lipid keratopathy, right? Something like this, right? Why I am specifying this? Because this is not Arcus. Arcus senilis is different. We will talk about it. So, this lipid keratopathy, which is irregular deposition of lipids on the cornea, can either be primary or secondary. Primary means we do not know the cause. And where is this deposition? Again, answer is same. Deposition is in stroma. Okay. So, either it is primary or secondary. Secondary, we know the cause. Here is the exam question, most common cause, and we answer it is viral keratitis. Okay. So, herpes keratitis. Mainly we are talking about herpes simplex and herpes zoster. This can lead to lipid keratopathy. Mainly it is the zoster part more. Right. So that was about the chronic eye disease. Generally it is commonly zoster. So here we are learning. Coming to relapsing. Relapsing means that the whole thing is reactivated. So that is happening after several years. So we call it a relapse. If the whole features, all this presentation is relapsing after several years, right? So if everything is relapsing after several years, this becomes a relapsing eye disease. So what will you write here? Reactivation after several years. Reactivation after several years. Okay, so that was about the clinical feature, acute presentation, chronic and relapsing. We come to investigation. Of course, it is the same as simplex that you have learned. Clinical is the most common. We can go for PCR. We can go for gene star staining to find the giant multinucleates. But generally, just remember it is the clinical diagnosis which is more common. Otherwise, PCR, right? So, if you want to write it, we can just say it is same as herpes simplex that you have learned. That is, clinical is most important, or we can go for PCR. We next talk about is treatment of zoster. Of course, here zoster, of course, topical is same as you have learned for simplex. Okay? So, again, we will learn like this. Treatment mein, apart from topical, we have to give systemic here. Unlike in simplex, topical may be enough in majority of the case. But here, we have to give both topical and systemic. And topical, it is the same as you have learned for simplex virus. What did you learn? 3% acyclovir to be given 5 times a day, or you can use 0.15% of gang cyclovir gel. Right? When you talk about systemic, what are the options? Systemic, what are the options? Let's note down. This time for systemic therapy, if I give acyclovir, the oral acyclovir is not going to be 400. It is 800 milligrams, which is given 5 times a day. Okay? 800 milligrams. If you don't want to give 5 times, you can change it to, or we can go for oral valcyclovir. Valcyclovir is also, this time you will answer 1000 milligrams, which is given TDS. 3 times a day. Right? Instead of 5, if you want to go only 3 times a day, you can use valcyclovir. That is 1 gram. Of course, all this therapy, whether I am talking about the simplex or I am talking about the zoster, majority of the times it is enough to give the treatment till 14 days. 7 to 10 days is optimum, but okay, you may extend till 14 days. So, generally all this treatment goes from 7 to 14 days, you can say. So, what did I say? Normally the treatment of antivirals should be up to 7 to 14 days. So, if the patient overtreats himself, generally thinking, okay, let me continue for a month, maybe I'll be relieved of the symptom forever. It never happens though. So, if he continues for a month, what is happening is metaherpetic keratitis. Now, this is your exam question. What is metaherpetic? This time the ulcer is not healing due to toxicity of antivirals. It is not healing due to toxicity of antiviral drugs. Got it? So, it is not healing due to toxicity of antiviral drugs. So, how do you manage it? Common sense, stop antivirals and start with lubricating eye drops. Start with lubricating eye drops. This will help to heal the epithelia. Okay. So, when you say acanthamoeba keratitis, do we know acanthamoeba is a ubiquitous protozoa present everywhere, and therefore it's quite rare to have this infection in the cornea as such. So, first important point is that it is a rare infection. So, what is the situation when it occurs? This is your repeated exam question. Okay, so we will answer. It occurs in soft contact because soft contact lens has more chances of infection. So, we answer here soft contact lens users. Washing their lenses with tap water. Washing their lenses with tap water. Okay, or another situation can be that you are wearing your lenses and you are swimming without your goggles. Okay, so that can also be a high risk for acanthamoeba infection. Now, suppose your question is most common infection after contact lens use. So, please don't answer an acanthamoeba. Why? Because I hope you're writing the question along with me. Most common infection after contact lens use. Now your answer is Pseudomonas. Okay? So you don't answer acanthamoeba because as we learnt, it is a rare infection. So when will you answer? When the question language of the question is something like this. Contact lens users are more prone to develop which infection or which rare infection, then we answer acanthamoeba. Just be a little careful. Whenever most common is given, you have to answer Pseudomonas. Otherwise, you can answer acanthamoeba. Right? Now the life is simple. Okay. Then we talk about, once we know this, next is clinical features. Of course, the presenting features are the same 6 features which we have learnt. And pain here again is disproportionately much more. So they ask you this is asked, why is the pain more? Because of perineural invasion. Okay? Perineural invasion, it can lead to radial perineuritis. Therefore, it causes so much of pain due to radial perineuritis. And very important, this is actually considered the pathognomic feature of acanthamoeba. Okay? That is radial perineuritis. For the same reason, it can sometimes also lead to thickening of corneal nerves. We'll come to thickening of corneal nerves after a while. Anyway, we talk about on examination. When you examine this patient, again let's make a diagram here. If this is the cornea, what you can get is a ring lesion. Very important, first is ring lesion. Have a look. So, this is a ring lesion of acanthamoeba. Apart from that, we may sometimes get pseudodendrites. Apart from the ring lesion, write down on your, if you want to write, you can write on your diagram itself, pseudodendrites. Okay. So, on the diagram, please note down. It can sometimes present as pseudodendrites are also called microdendrites. Pseudodendrites or microdendrites. Anything else? What is the next feature you can get? We will note down, of course, apart from, number of radial perineuritis is there. Don't forget that. Apart from that, limbitis. Okay. So, there can be limbitis with stromal infiltration. Sometimes this ring lesion can be associated with abscess formation. Okay. So, that can be another presentation. This is the presentation or on examination finding. So, you can note this down on a diagram. Sometimes it can be associated with infiltration and abscess formation. Okay. Once we know this, we next talk about is investigation. Give the heading investigation. Either I directly see this on confocal microscopy, by microscopy, right? If I am directly visualizing in confocal microscopy, what I see will be double-walled cysts as bright spots. Okay? So, we see some bright spots with double-walled cysts. So, this is important. And this has been your exam question about double-walled cysts. So, we make a Q here. Of course, apart from that, our investigation constitutes of microbiological investigations. Apart from this, of course, this is also microbiological only. I mean to say staining and culture. So, when you say staining and culture, what is the stain we can use for acanthamoeba? You will answer number 1, this again chalcofluoride. You have learned chalcofluoride for fungi also, here also. Okay. Then you can also learn it can be PAS, periodic acid shift. Third, you will note down is acridine orange. And to complete the list, we can also note down Giemsa stain and Gram stain. Talking about the culture. Culture we will learn is non-nutrient agar with E. coli. This is your exam question, all of you. Double Q please. Non-nutrient agar with E. coli. Right? So, E. coli, what is the role? This is the trophozoites are feeding on the E. coli, right? So, that is why we add E. coli because trophozoites, so it has both form, the cystic form and trophozoite form. So, trophozoites feed on E. coli. Right. What next? After this, we talk about Treatment of acanthamoeba keratitis. Give the heading treatment. What is the drug of choice has been your exam question, and what should be your answer? PHMB. What is PHMB? It stands for polyhexamethylene biguanides. Polyhexamethylene biguanides. This is PHMB. Right? Uske alawa, what else? This PHMB is generally given as 1 hourly interval. Along with that, what is added 1 hourly is chlorhexidine with chlorhexidine eye drops. This is how you treat. But whenever they ask you the drug of choice, your answer will be PHMB. Check. What can be the other drugs which can be used, which are effective against this? Second we can note down is amides, that is propamidine isethionate. Okay, so diamidine group, diamidenes, that is one name that you have to know is propamidine isethionate. And of course neomycin. But neomycin, what is the disadvantage? It is only effective against trophozoite form. Okay, so only acts on trophozoite, but we can give neomycin. What else can be given? There can be azole group of antifungals that can be given, like voriconazole. Okay, so azole group of antifungals. Even this can be effective against, antifungals can be effective against acanthamoeba. Right? And of course, for the pain, you may have to give non-steroidal anti-inflammatory drugs for pain because pain is too much here. Right. So that was about your acanthamoeba keratitis. Okay, well, let's give the next heading. Next heading is interstitial keratitis, IK. Let's learn according to my style. Interstitial keratitis, just simplify like this. Make a diagram here. It simply means epithelium is normal. Okay, in my style, endothelium is normal. And what is affected? What is affected is only stromal. So, it's a pure stromal keratitis. This is called interstitial keratitis. Right? And majority of the time it is immune mediated. Majority of the time immune mediated. Why it is happening? Etiology. We can divide the etiology as syphilitic or non-syphilitic. Either it is syphilitic or it is non-syphilitic. Right. So, talking about syphilitic means it is due to syphilis, and it's mainly the congenital syphilis, which is transplacental infection. Okay. So, it is congenital syphilis. What about the non-syphilitic? What are the causes? So, let's have a look first here. So, if you look here, this is what is pure stromal involvement. This is stromal keratitis. Talking about non-syphilitic causes. So, just remember all the granulomatous inflammations like tuberculosis, leprosy, right? What next? Sarcoidosis. And of course, to complete the list, even acanthamoeba can be one of the causes. Then there can be herpes. You just learned this, that herpes zoster especially can lead to, as a hypersensitivity reaction can lead to. But it is said that theoretically both simplex and zoster is mentioned, which can lead to interstitial keratitis. Right? And lastly, we should not forget is Cogan syndrome. What is Cogan syndrome, guys? So, Cogan syndrome is interstitial keratitis with deafness. Okay, so this is called Cogan syndrome. This is interstitial keratitis with deafness. And yes, one more that you have to know is onchocerciasis. In the list, I am adding one more, onchocerciasis. Okay, now coming to one exam question. The question says, salmon patch is a feature of. So, can you see this? What is salmon patch? It's a patch of bleeding in the stroma. So, this is your exam question. It's a feature of. S for S, let us learn like this. It's a feature of syphilis. So, why is there bleeding? Cornea is avascular. So common sense, because of the infection, because of inflammation, there is new blood vessel formation and that is bleeding. This is what is Salmon patch. And when the blood is all gone, what is left are ghost vessels. When only the vessels are seen, these are called ghost vessels. So what is the treatment? Next we talk about is what is the treatment. Because the majority is immune mediated, we are giving topical steroids, right? And in case of Cogan syndrome, we may need to even give, along with the topical, we may need to give oral. So Cogan syndrome, along with the topical, what we need to give is systemic steroids. Or sometimes what is needed is also immunosuppressive drugs. Immunosuppressive drugs. Immunosuppressive therapy may be required. Correct? Anything else we want to mention in the treatment part? Every keratitis can also lead to uveitis. So, treatment of associated uveitis. That is, along with the steroids, you have to give cycloplegics as well. So, here we have to give cycloplegics. Now, one interesting piece of information, though in syphilitic infection, please remember systemic, that means penicillin injections have no role. Okay. So, let's keep this in mind that in syphilitic interstitial keratitis, systemic penicillin has no role. Let's also learn about what are the ocular features of syphilis. So, we give the next heading as what are the ocular features of syphilis. How do you learn the ocular feature? We will make a diagram, right? So, let's start thinking outside to end. First, let's make the diagram. What are the ocular features of syphilis? I think now you must be expert in making this very, very oversimplified diagram, right? Okay. So, one by one, first important thing is, of course, interstitial keratitis. We start with this. Second uveitis, it can be generally granulomatous or non-granulomatous, but generally granulomatous anterior uveitis. Then it can lead to cataract. And of course, let's not forget in the pupil, in neurosyphilis, can lead to Argyll-Robertson pupil. What was Argyll-Robertson? ARP, accommodation reflex present and light reflex absent. And lastly, we have learned this in the retina. We will write here salt and pepper fundus. Okay, so this way you will never forget the ocular features of syphilis. So we are talking about salt and pepper fundus, cataract, ARP, uveitis, mainly anterior uveitis, and posterior uveitis, of course, is salt and pepper. What is salt and pepper? We have discussed this even in your diseases of lens chapter, that this is nothing but diffuse chorioretinitis, where there is pigmentary disturbance, which looks like salt and pepper. So that's what we are saying, right? And of course, Argyll-Robertson pupil, I have mentioned that. Okay.